in the entire Baptist system. We've done a total of 736,473 total PCR tests. If we look at testing system-wide, we've tested 422,892 people for a total of 66,089 positives, or 15.3%. And if we look at Baptist Memphis alone, it's 66,903 people we have tested, and that's a total positivity of 6,850. And that's a 9.9% positivity rate. If we look at the hospitalization numbers right now, at Baptist Memphis, there are 18 people in the non-ICU acute care beds with COVID-19, and there are 13 people in the intensive care units with COVID-19. That is a total of 31 now, not quite our peak over the last week or so, but staying at that sort of plateau, significantly higher, on the order of 3 times higher than what we saw before. 10 of those 13 people in the intensive care units are on ventilators, so a fair number are quite ill with that. And I might add, a significantly younger population for a number of reasons in that circumstance. At Baptist DeSoto, there are 10 people in non-ICU acute care beds with COVID. There are 3 people in the intensive care unit with COVID, and one of those 3 is on the breathing machine, the ventilator. So the numbers staying obviously higher than we would like. At least they have not gone up dramatically at this hospital over the last few days, but they're sort of staying at a plateau that makes us all a little uncomfortable, but glad so far that it hasn't risen higher. So, happy to answer any questions.
Hey, Dr. Threlkeld, Channel 5.
Hey.
Can you elaborate a little bit more on the ages that you're seeing in the hospital, especially those who are on ventilators and sick, and what do you take of these continued reports from elsewhere about kids, minors in the ICU with COVID-19?
Yeah, so it's very obvious that the people in our ICUs are younger, and the people in the hospital are younger, and to the point of 10 to 15 years younger on average than what we had seen sort of the first episode of this, or the first surge, if you will. And there are a number of reasons for that. I think number one is a lot of the older people have been protected by vaccines, and so they are much less likely to get admitted to the hospital and or die. So we really take a lot of those folks right off the top, thankfully, as protected and unlikely to be here. So you're dealing with a lower age population who is non-protected by vaccine in the first place. And then, of course, you sort of dovetail that with the fact that, as a society, we've kind of moved past this thing in our behavior and in our expectations. So people are mixing and mingling a lot more freely than they did before. And I think a lot of people are not reaching for masks. Partly correctly, I think. I mean, outdoor events are very unlikely to be dangerous for much of anybody. But I think indoors, obviously, as we've said many times, particularly if you're unvaccinated, you need to do those mitigation techniques because you're significantly at risk for a much higher contagious virus now that can get to you more easily. So for both of those reasons, we're dealing with lower populations. But it is disturbing for us. And, there are a lot of people that still don't take this very seriously, and I always wish I could take people for a trip through the ICU, because we have people right now in this hospital on ventilators in their 20s, their 30s, their 40s, and so we see a lot more of this than we saw to begin with. Now, almost all of them are unvaccinated. We have had, I can think of probably 3 deaths of vaccinated people. Not all of those were immune competent or normal immune system people, so those folks are kind of a special case, but a couple were, and so it still can get to someone. But again, I want to be very careful to emphasize the fact that that is not the fact that it rarely breaks through clinically and makes people sick is not a reason not to take advantage of the dramatic safety that you get from that vaccine, more than 90%. So the vast majority of people in our hospitals are unvaccinated, and so that's what we're seeing, and it is sort of disconcerting to see people in their 20s, 30s, and 40s who are on the breathing machine and in danger of losing their lives. And I ask everybody, did you get vaccinated? And the vast majority say no, if they're still awake and alert and can talk to me when I evaluate them. And it's distressing.
Thank you. And, I've been trying to get some reports on some of the minor ICU stays in other states just to see, ages, if they are immunocompromised. But speaking of those who are immunocompromised, Dr. Dobbs in Mississippi late last week had said regarding some of these breakthrough cases we've been seeing, saying, if you do have, maybe conditions that could weaken your immune system, to get the immunity check to see if you have the antibodies. And then, even went to say, inquire about a possible third shot. I clarified that with the Mississippi Department of Health, and they said that, yep, it is what they said, and they are encouraging providers to to take it case by case. So is a third shot possible? What are people saying about something like this, especially in immunocompromised people?
Yeah, and let me make one point even before the immune compromised third shot, is that other things beyond just impaired immune system are apparently putting people at risk. There are a lot of people younger, as we mentioned, but other medical risk factors seem from the beginning to have come into play largely, particularly weight. People who are morbidly obese have done historically very poorly in our experience and in the experience of so many others. So somebody who's particularly overweight is at a huge increased risk, and really would emphasize that those folks need to get the vaccine, because a lot of those folks have normal immune systems and can get the full protection. Now, with respect to the impaired immune system, should you get the third shot? It's always complicated to make a comprehensive recommendation when the data just are really not there in large numbers to do it. And if you look at the bit of data that we have, Johns Hopkins came out with a study, particularly on transplanted patients. Chemotherapy patients seem to do a bit better on average in making their antibody. I called a guy today who has an immune compromising, hematologic or blood cancer malignancy, and he had a spectacular response to the spike protein antibody by the vaccine. So, and didn't have any antibody to suggest he'd ever been really infected by the virus. So you can still get a great response in some of those folks. In solid organ transplants, heart transplants, kidney transplants, they particularly have a tough time generating good antibody from the vaccine. And just the piece of information, the study that fed a lot of this discussion, was that they took the patients at Johns Hopkins and they gave a third vaccine. And of the people that generated no antibody whatsoever, about a third of those people generated some, generally not a lot, but a little bit. And of the people that had generated some antibodies, but not enough, all of those did have a nice bump in their antibody. Now, I emphasize that number of those people is 6. So it's not like they did this with 1,000 people. They did it with 6 people. And all 6 of those people did get a nice bump in the antibody. So that led to increasing studies that are being done now, and we will probably get good data coming out very quickly. My own feeling is, and what I do with patients, is somebody significantly immunosuppressed, we have for a time now been looking at that, indeed on a case-by-case basis, but not infrequently checking their spike protein antibody. And the side caution is that the regular SARS-CoV-2 antibody that people get from a doctor's office is frequently not the spike protein antibody. It's the antibody for a different protein called nucleocapsid. It's just listed as a total SARS antibody. And when they get that, it's going to be negative if they haven't had the natural infection, whether they've had the vaccine or not. So a lot of people are coming to me saying, my gosh, I got the vaccine, I don't have any antibodies. When you look at it, they didn't get the spike test. So we have to test it again for that particular antibody. But still, some of them haven't. What to do after help that we saw in the studies, we would recommend that you go get that third shot, because you're a lot more likely to be helped by it than hurt. You're very unlikely to have a problem from a third vaccine. This is all conjecture. It's fairly informed conjecture, but I literally have to sit down with somebody and say, okay, here are the options. We can give you a third vaccine, and it might, I emphasize might, bump up your antibody level. You might already have T cells that are protecting you more than that antibody level even tells us. We don't know, but we do think it's a low risk to get a third vaccine. Certainly there have been no reported problems of doing that. So it's very hard when the CDC and state and local health departments have never made any sort of categorical recommendation. One is almost certainly coming down the pike here, where we can be a lot more sure of the recommendation. But again, I do exactly what the folks in Mississippi are telling you. I take it on a case-by-case basis. And if somebody is really having a hard time sleeping at night and very distressed by that and is unable particularly to do some of the real mitigation things, separate from other people, wear masks in their daily setting, then those are the people that you would consider giving an extra vaccine to.
Hey, it's Briseda, also with WMC.
Hey.
So I was wondering, I kind of joined late. Can you talk about double infection? I'm sure you're familiar with what happened to the woman in Belgium. She died after being infected with 2 variants. So just trying to localize that. What are the odds of something like this happening here? Are there 2 strong variants in the Mid-South?
Well, sure, it's always possible. What's not at all clear is what that had to do with the severity of her illness or, in fact, the cause of her death. There are a lot of places around the world where there are multiple variants present. We are one of them. Right now, we still have plenty of alpha variant left. It's rapidly being overtaken by the Delta variant, and soon there will be little to no alpha variant left, just like the original Wuhan or wild type variant was here. And as alpha was replacing it, they were both here a lot. There's very little, if any, of the original Wuhan left, and now there's decreasing number of the alpha variant, simply because the Delta variant is more contagious. It spreads more easily, more rapidly, and efficiently, and so it just chokes out and takes over the alpha variant. Now, interestingly, that 90-year-old lady in Belgium who died fairly quickly did have, I believe it was the alpha and the beta variant, which was what we used to refer to as the South African variant before we assigned Greek letters to all these things. The South African or beta variant is sort of a little different, from the Delta. It's a little more in its mutations likely to cause infection in people who've already had prior infection. So if you've had antibodies to, say, the Wuhan strain, the beta and the gamma, for that matter, too, the one in South Africa, they tend to do very well at reinfecting people. They do not respect the immunity that we have generated based on the original Wuhan virus. So it's not at all clear yet that this woman succumbed to this infection because there were 2 different strains infecting her. We just don't know the answer to that. It's obviously just as likely that she was just 90 years old, and a lot of 90-year-old people do very poorly with this infection. But it not only is possible, it's extremely possible that you could have that in Memphis right now. We have the alpha and the delta variants going on right now. We may even have it going on in larger numbers of people than we realize. Now, when an immune system really revs up and starts attacking one variant, it's not an opportune time for another variant to try to sneak in the door, because the immune system guns are blazing, and already the viruses are being beat up on very aggressively by the immune system. So it's harder after that's fully underway for another virus to sneak in. It's more likely, I think, that both of those viruses infected her at a very similar time frame before the immune system could really rev itself up to the extent that it did. So, I think it's probably something that does happen. We see it in other viruses. Influenza can do that on occasions. So co-infection of viruses, even with different viruses altogether, flu and COVID, we saw back in the beginning, before we really exercised some of the social distancing things that really cut down on the flu aggressively. So I think you'll likely see it if we were just to sequence a lot more people. But I think we're a long way from knowing that having an infection with 2 different variants at the same time makes a lot of difference in the outcome. It may be that we'll see more cases. We'll be able to study that a little bit more clearly. But the more variants you have, obviously, the more likely that is to happen. And for a little while longer, we certainly will have 2 variants circulating here locally, but very soon we will, I think the alpha will be pushed out almost altogether.
Do you know how many variants there currently are?
Well, the ones of concern, there are probably a lot of variants, but the ones that are of the most concern right now, obviously the alpha, which is the old UK term, which was the original increased contagion variant. It was quite a bit more contagious than the Wuhan or baseline or wild type variant. Then the beta variant is the one that we mentioned that infected that Belgian lady, and it was previously referred to as the South African variant. Also more contagious than the original Wuhan wild type, and it also has this propensity to infect people who've already had previous infection. The Gamma variant is the one from Brazil that was first seen there. And it was notable for the fact that in one town in Brazil, for example, Manaus, they had been hit very hard earlier on in the pandemic, such that they really thought that that they might be reaching herd immunity. They had very high infection rate. And then lo and behold, months later, here comes this new variant, the Brazilian variant, named for there, now Gamma, and it tore through the city again, infecting many people again, just as if they didn't have any immunity from the original Wuhan variant. So, and it also is more contagious. It is to some degree in the United States. It took a bit of a foothold in Washington State recently. 16, I think, percent of their variants there were Gamma variants. So we don't know how it competes head to head with the Delta. If both of them are in the U.S., it'll be interesting to see. Delta seems to have the upper hand on everybody else right now in the U.S. and everywhere else for that matter, because it's just very efficient. And then Delta, we've already talked about. There is this new variant called Delta Plus, it's referred to, and it's the same as Delta with one additional mutation that really it shares with the South African variant. And the reason that's important is that in addition to being more contagious and more problematic in that way, it also may have a little more in the ability to shake off immunity from previous infection, like the beta does a bit better by itself. And it also makes it a little bit more resistant to some of the monoclonal antibody therapies that we still use with great success in high-risk people that come in with coronavirus. We give the monoclonal antibody, and the numbers are quite good at that, at avoiding more serious infection in people who don't have previous infection, particularly with the vaccine. So those are the main ones. There are other ones out there. And the problem is, of course, that the way they arise in the first place is simply because the virus is making copies of itself, and it makes mistakes or mutations. When it does that, it may lead to characteristics of that virus that make it more problematic for us, a more formidable opponent, if you will, for our immune system. That's what we're trying to avoid by simply cutting down on the replication. It's why vaccination and avoidance of the infection nationally, let alone worldwide, is so important, because we have our own variants cropping up probably in this country right now. We haven't seen any yet that made a big clinical difference. If we do, we might see one that starts taking over and is more contagious. To some of my patients, I explain to it as, it's like you're on a sports team and you're playing against a basketball team that you play them 4 times in the season. And every time you play them, they replace some of their players with taller, faster, meaner, better folks. And every time you see them, the old players are kind of on the bench or maybe even off the team altogether. We don't see any of the Wuhan original stuff anymore. So you're basically taking on more formidable opponents. And when you start playing that team 4 and 5 times later on, it's a lot harder. And that's that's the slow road that we have been on in these variants. And it's a road that we need not to sort of go too far on. And it makes people talk about booster vaccines, and they can be very important. But so far, our immune systems haven't really waned very much from these vaccines. They still perform fairly well. But if the variants get different enough from the original, immune response, such that our antibodies don't stick very well to them and don't very well, then you will need not so much a booster, but one of the new variant vaccines. Thankfully, with the RNA vaccine technology, that can be done very quickly. And certainly those tests are already underway. So we hope to have an answer for that. But the farther we go in this direction with the variants, the more likely we will be to need that answer.
Hello, doctor.
Hi, Alex. How are you?
Doing well. Thank you very much. Wanted to ask you or get your, feelings about the low vaccination rates still in Tennessee, Arkansas, and Mississippi. Of course, there have been reports as recently as today that Tipton County, one of our neighbors here in Shelby County, could have one of the highest 14-day increases of COVID cases in the country. What are your concerns about this?
Yeah, and Tipton County is near to my heart. My grandfather was the first elected county school superintendent in Tipton County during the Depression, and my mom grew up there, so I have some familiarity with Tipton County in a lot of ways. It certainly has been the case that more rural counties all around the country, certainly in our region of the country, have had a lower vaccination rate. There have been a lot of explanations for that, and people reach for political answers to that, and that is in no way an area of expertise for me. But I've always said, and I may have said it to you before even, that the political aspect of me mystifies me, because really politics these days is broken down into sort of Trump and Biden, and both of those candidates, they say that they are responsible for the success of the vaccine. So it's not like one side is logically in favor of or not in favor of the vaccine, in my estimation. I just don't see the political aspect of it, honestly. And so could it be that more rural counties are harder to get to physicians? They have a lower density of physicians, to be sure, and of hospitals, to be sure. So it may be that that's a factor as well. What we can't deny is that it puts us in a bad situation. I mean, being unvaccinated in larger numbers is just a magnification effect that we don't want to see right now with a more contagious variant. We haven't had time here to see death rates climb, but if you look at what happened in the UK, we're sort of a month behind their curve, and their curve took up sharply and had a huge increase in cases. And ours is sort of a month behind, but it has turned up to that same slope on the trajectory of that graph. And so, and we, unfortunately, because we are where we are and surrounded by states and counties that are very poorly vaccinated relative to the rest of the country, we're in the crosshairs of the problem that's coming, however big it turns out to be. Thankfully, the vaccinated people happen also to be the people who are the highest risk of getting ill and dying of this infection. So that will alleviate some of the congestion and pressure on healthcare facilities themselves. But it is very, very exasperating to healthcare workers, because essentially almost every death that we watch is a preventable death at this point, whether you're from Tipton County or Shelby County or wherever. So I would say that the practical point there is that you're going to have people who've gone out and gotten their vaccine. They've done what they can do, and they should still, in my estimation, be a little careful when they're in crowded situations. I always have a mask on me. I may not wear it as much as I used to, but I still do in crowded indoor situations. So I think that's helpful. But then you have the group that is just not going to get the vaccine. They're either afraid of it, and again, that's its own discussion. A lot of them are afraid of long-term consequences, something that really doesn't exist for viruses, for vaccines. There are some short-term consequences, but very few. Nobody grows some new problem a year down the line from vaccines. They never have for any vaccines. It's never been a reality for any vaccines. But what we do have is tremendous long-term problems from COVID itself. So when somebody's doing well, the normal human mindset is, I'm not going to take a chance on getting the virus. Unfortunately, they're not realizing that their choice is, in fact, a choice to take a higher risk in not doing anything. So that's something that we have to get past. And then the most important, I think, the thing that's remaining in getting people vaccinated is simply this: we have to put it at their doorstep and offer to roll up their sleeve for them, because I think there are still a lot of people out there who it's just an inertia thing. Guys are worse about that than women are, in my experience, being a guy. But we need to have it at their doctor's office. We need to have it around the corner for them. We need to take it door to door, because I think if you really get right up to people with it and give them the opportunity to get the vaccine, you would get a lot more people vaccinated in that circumstances. We certainly are trying to increase it in the hospital because we had the vaccines here. So, and we need to do better at that. I certainly do. I'll tell somebody in the hospital, hey, I'll talk to them and encourage them to get the vaccine. They'll say, okay. I'll say, okay, we'll be back and we'll get it before you get out of the hospital. We need to make sure that happens. But I think there's a fair amount of that could play into the whole rural motif as well, because they may be farther in rural counties away from a doctor's office or a shot that is available. We need to make sure that we get it as close to them as we can, so that it's no problem and no effort to get that vaccine.
Dr. Threlkeld, I think Jane may have had a question, Jane Roberts.
Okay. Jane, you there?
Can you hear me, Dr. Threlkeld?
Yes, Jane, you're there.
Tennessee is really in the news today, in the vaccination news for the nation. Is there any way that it's not true that we're anti-vaccine here?
Say that again, Jane. Is there any way that what now?
Is there any way that it would not be true what the headlines in the big dailies around the nation are saying, that that the anti-vaccine group is winning, that it's hysterical. And I mean, is there a more nuanced way to look at this?
Well, I think there are just a lot of factors, and I think, I mean, just is to go back to the other point. I mean, there are a lot of rural counties, more so in Mississippi, Tennessee, Arkansas, Missouri, than there are in some of the more urban-centered states around the country. And so I think it's harder sometimes to get the message out in that situation. And again, it's harder to get the vaccine into their arm physically and logistically in those situations. So I think there's a factor there too. I'm certainly frustrated in talking to people. For me, if you look at the people who really refuse the vaccine, and I talk to a lot of people about this on the ground, in the hospital, who are here, I'm still gratified by the fact that there are those who say, you know, they've got COVID now. We can't help them at the moment with a vaccine, but they'll say, well, I was going to get it. I just hadn't gotten around to doing it. But I want it now. I think, well, we'll have to wait a little while now until you get well. So I think there still are some people that we can do that for, and that we can educate, and we can make it convenient to get that virus. So I think that's somewhat nuanced. They're not really anti-vaccine so much as they just haven't gotten around to take the energy to get it. So I'm encouraged by that. But I think a lot of people simply are afraid of the vaccine. It's not that they don't believe in vaccinations per se. They've gotten their measles and their shingles vaccine, for that matter, a vaccine that has higher side effects than COVID-19, certainly. The COVID-19 has been sort of likened to be somewhere between the flu and the shingles vaccine in terms of side effects that you would have, flu-like illness and fever and the like. So they would have gotten those. They're just afraid of this because it hadn't been around a long time. And I probably, I think I've talked to you about this before. The thing I tell people about that is that, look, you can be a reasonable person, jump off the diving board. It's not that he doesn't understand that he needs to learn to jump off the diving board, and his kids or friends are going to make fun of him if he doesn't. He doesn't not understand that dad is sitting there at the base of the diving board is going to catch him. He's just still afraid. And as I say, I complete that analogy, however, by pointing out to people that the analogy is not accurate unless you put a snarling dog at the other end of the diving board that's going to walk up and bite him in the backside if he doesn't jump off. That's really more of what a true analogy would be to it. So I think that education for people is very important. Yes, there are some people who are just anti-vaccine, and we certainly see them. But I don't see as many of those people as I see of the other groups that I'm describing to you. Yes, I see people who are hostile to vaccines, and I can show you comments from them to be sure in our get together here. But I think those people are more loud than they are persuasive and overwhelming the discussion. So I think it's just a matter of educating people and overcoming their fears about this. Yes, it's a vaccine that's been out a shorter time than other vaccines, but it's been more heavily studied than any vaccine in history. And the safety is enormous. And if I can just as a small aside, which I am prone to do, let's look, for example, at the Guillain-Barré situation, and that's come in the news here recently. Guillain-Barré syndrome is sort of an acute neurologic event that's common it happens in viral infections, some bacterial infections, and indeed some vaccines. We saw it in the swine flu vaccine in 1976. There was a very large number of people comparatively who came down with Guillain-Barré syndrome. Some of them have tingling, numbness, even paralysis that rarely can even be dangerous. Now, 70, 80 or more % of those people completely recover within a few weeks. So it's seldom anything like a life-threatening illness. But even in that worst year for Guillain-Barré ever, you still had a higher likelihood of dying from influenza that year. That is, dying of influenza than you did to even get Guillain-Barré syndrome, something that has a nearly complete recovery. So you have to stay with the statistics. And if you look at the Guillain-Barré numbers, I think I may even have some written down, the Guillain-Barré numbers, you have 3,000 to 6,000 people per year that get Guillain-Barré anyway, just from viruses and other sorts of things. With this vaccine, the J&J vaccine, 13 million people have been vaccinated in the United States, and that's shown about 100 total cases of Guillain-Barré within 45 days or so of that second dose of the vaccine. And it tends to be in men in their 50s. my point in all of this aside is simply that your odds of dying of coronavirus is dramatically higher than your odd of ever getting anything like Guillain-Barré syndrome, something that is largely completely recoverable in a matter of weeks. So the statistics they just don't bear out. So again, I think that education and dealing with people's specific fears, we need to take the message to people, door to door if necessary, but through community and municipal and church groups. We need to give people the opportunity to ask questions. And that can be sometimes harder in more of a rural environment in the country than it is in some of the urban ones. So again, I'll just say that I don't think it's purely the anti-vaxxers shouting down in Tennessee the people that are not. I mean, we have taken our seat in the high rate of infection share twice. This happened months ago when we were the #1 place really in the world for vaccine transmission. And now the unfortunate thing, though, is that we're back in that seat, and plenty of other people have had that be the case as well around the country. The fact that Tennessee is in it now again does not mean that we have any other particular social problems about this. But I think it is unfortunate because they're preventable now. Unlike what we experienced the first time when it was rampaging through Tennessee, now we have a way out, a prevention, a reason that this doesn't have to happen. So I think it's just education ongoing that we have to really cling to at this point.
Thank you, Dr. Threlkeld.
Thank you, Jane. Any other questions? Time is short, so I want to answer just a couple of questions. Joey Rosas, who's one of our chaplains here at Baptist, wonderful guy. He asked the question, what about the option of a second vaccine of a different kind in those who are already vaccinated? A lot of work is being done about this right now. We found some mix and match studies over in England that a particular array of 2 vaccines in a row did very well. So it's a very important question that's being studied right now. We don't have enough data right now to suggest that people, in fact, take a Johnson & Johnson after a Pfizer rather than a second Pfizer. We don't have enough information yet to say that, but that very question is being studied, and we hope to have more data about that pretty soon. But an excellent question. Vineet Singh asked, can someone please ask if the increased hospitalization of vaccinated people is due to the Delta variant? I think the answer is a guarded yes. We have certainly seen a lot more hospitalizations because of the more contagious virus. And I think there's some resistance to this Delta variant, to everything, to vaccines, to former infections without the vaccine. So we found that one vaccine doesn't do the job really much at all anymore. So that's some resistance. But still, 2 vaccines does a very nice job of preventing serious illness and death. So an important thing that we will have, again, more data on pretty soon. Gloria Ann asked, when can you get the vaccine after having COVID? It can be as little as the 10 days it takes you to become non-infectious and to get somewhere to do it for the safety of the person giving you the shot. Frequently, people take a little bit longer to do that, but you don't have to wait any particular amount of time, particularly since these new variants that are out there do have some ability to get past your immunity from the real infection. So it's probably a higher stakes to go ahead and get vaccinated now than it has been in the past. Lisa Cockrell asked, why do so many feel that immunity from the vaccine is considered better than immunity from actually contracting COVID and having strong antibodies? And that's, again, a very good question, similar to the last one in that I think immunity is very good from the natural infection, unless you have variants that you're facing, which we kind of are now, that don't respect that immunity as much as it used to. So we're in a much more, we're in a situation now that's much more likely for you to benefit from getting a vaccine. It boosts up your numbers of antibodies dramatically, which might not only protect you more now, but also lengthen your protection. And then secondly, it adds protection against some of those variants that the natural infection may not fully protect you against. So that's really the reason why we push for that in addition just to the natural infection alone. I think that's all I have in the way of questions at this point. Any other questions? Okay, thanks very much. Have a great weekend.
Thank you.